Matthew DeClercq, I don't think that is a PPE safe and standard beard that you have there.
Yeah, it's my way of staying out of shifts. So no, I'm not shaving. I'll shave my head. I'm not going to shave my beard.
You're very controversial, man. A controversial figure with that. I'll tell you, something else is controversial, giving steroids to patients with spinal cord compression, spinal cord injury and trauma. But where is it less controversial when you've got the spinal cord compression? What type of patient?
I'm going to say it's the spinal cord compression from the neoplasm. Those Mets, definitely. You give me the roids. I need the roids for that.
That's some good foreshadowing. That may come into play in a few minutes. Dr. Morrison, what do we need to know?
All right. We are talking about acute spinal cord compressions here. And like you alluded to, Rabio, we're going to be talking about a few different types of mechanisms of injury here. Acute spinal cord compression, we all know, but this paper reviewed in the New England Journal talks about 4 main acute types of spinal cord compression, including trauma, tumor/neoplasm, epidural abscess, and epidural hematoma. So we're going to talk about each of these. Now, we know based on exam, cardinal symptoms include symmetric paralysis, urinary retention or incontinence, and loss of sensation, that saddle anesthesia we always are looking for. Now, patients may have localized neck or back pain. They may have hyperreflexia or Babinski's, may be absent, especially in trauma. So don't forget to do a really good neuro exam and sensory exam, including spinal percussion. And then be careful, do a careful, detailed neuro exam on all these patients. So starting with trauma. Now, the main concern with traumatic spinal cord compression is this retropulse bony fragment. So those bone fragments that sort of repulse into the spinal cord canal. You can also get disc herniation and subluxation at multiple vertebral levels, depending on the type of injury. 20% of spinal injuries affect more than one level. So you know that if you have a thoracic injury, you're probably going to have one above or below. So the first study of choice in trauma is CT. Now, we may want an MRI as well, but really CT is the preferred initial study in a traumatic setting. That's different for neoplasm. We'll talk about that in a minute. But if you're in a trauma, CT is the initial way to go. Rob, as you so poignantly stated here, that the use of steroids with traumatic compression is actually pretty controversial. So you can speak to your neurosurgeon depending on, if they want it at their shop, but it is definitely not recommended across the board. You do want to watch for spinal shock, and so you want to treat their hypotension. And these patients require early surgical management. You want to get those bony fragments out of that spinal canal and take the pressure off the spinal cord. Now, this is a completely different beast. Those patients with that terrible neoplastic epidural spinal cord lesion, right? So these patients will come in with aching back pain that's worse when they're supine. They will probably have some percussive tenderness. You may or may not see some hyperreflexia and Babinski's. The most common types of tumors that cause this are breast cancer, lung cancer, prostate, non-Hodgkin's lymphoma, renal cell, and myeloma. And in kids, which is terrible, but it can happen too, sarcomas, neuroblastomas, and lymphoma. Most commonly, it affects the thoracic region and then the lumbar region and the neck last. And it, again, also frequently involves multiple levels. So here's the difference, is that MRI with contrast is initially the preferred imaging of choice. Unlike trauma, so neoplastic epidural spinal cord compression, if you're worried about that, MRI should be your first go-to with contrast. Now, what happens if a patient has an MRI contrast, like a gadolinium allergy? Rob?
Yeah, I was thinking if maybe they got some renal failure or some other issue, right? The gadolinium got some issues. You just do the MRI without the GAD. That's what I'm thinking. You just get it.
That's exactly right. So the other option is CT myelogram is the other option of imaging, but they will tell you that MRI without contrast is still superior to CT myelogram. So the answer is, if you have a neoplastic spinal cord lesion, you want MRI with or without. So that should be your first standard imaging of choice. And then the treatment for this, as you mentioned, yes, there's radiotherapy. Yes, there's surgical decompression. But at least in the emergency department, what can we start? Steroids. 100 milligrams of dexamethasone is indicated.
Wait.
So DeClercq, you would get your roids there.
100 milligrams? That sounds like so much.
It is. It's a big dose. All right. Spinal epidural abscess. Now, we see this in who? DeClercq, who do we see this in?
IV drug abusers.
IV drug abusers. Also patients with other immune suppression, right? Diabetes, cancer, Perhaps they're alcohol abusers or renal failure patients. So this is an often misdiagnosis. I mean, how many times have you heard these bounce backs in your M&Ms or patients who come back on their third, fourth visit, and then finally someone makes the diagnosis? Interestingly, for spinal epidural abscess, the thoracic region is the most common, and it's usually due to MRSA or MSSA. And these patients will have the same sort of radicular pattern of pain. They'll have severe back pain and potentially a fever, but may not. If they're immunosuppressed enough, they may not mount a fever. Imaging of choice is also MRI here. And on blood work, you're going to see something that looks a little bit more infectious. So leukocytosis you would expect, and as well as an ESR-CRP bump. Ultimately, treatment is surgical. Of course, you're going to start some broad spectrum antibiotics, but you need to really call your neurosurgeon. This is a surgical emergency. Similarly, spinal epidural hematoma, also a surgical emergency. These can present with severe back pain, radicular pain. This can be due to trauma and also spontaneous. So for those patients who are on those anticoagulants or antiplatelet medications or have an underlying coagulopathy, just know that these are the patients that are high risk, even with a pretty moderate size type of minor injury. So in summary, 20% of spinal injuries affect more than one level. So if you have it in one area, you should suspect it above or below. MRI with or without gadolinium is the imaging of choice in neoplastic spinal cord compression, as well as epidural abscesses. Steroids are indicated in neoplastic spinal cord compression, but not trauma. And Staph aureus is the most common cause of epidural abscess.